I'm David Adams. It's my great pleasure to welcome you to the 5th ATS Mitral Conclave.
Hi, I'm Dr. Randy Martin, and I'm joined by Dr. Steve Bolling, known to all of you, and a good colleague and good friend, Dr. Bolling. They're clapping for you already. It's fabulous. So let me ask you, you're giving a talk that 70% of mitral valve repair or surgery should be done minimally access way. What do you mean? What do you
Randy,
mean?
thanks for having me here. I'm going to say that 70% of the patients in the future, say 10 years from now, will have minimal access, but it's not what you think. I don't think robotics, or I don't think minimally thoracotomy-wise, there's really going to be that much. I think most of routine mitral valve procedures are going to be on a catheter basis. I think we'll always have sternotomies for very complex cases and redos and so forth, but I think very soon, just like we've seen in coronaries and just like we've seen in aortas, that these are going to be replaced by a toolbox of catheter tools.
And you're talking about the gamut of mitral valve. You're not talking P2s, and you're talking about people who have Barlow's. You're talking about people who have functional MR.
Well, obviously there's different ranges of mitral regurgitation, and we'll see it slowly accrue our toolbox. If you think of it, the standard for aortic stenosis is to replace the valve. I've taken 40 years to learn how to do it surgically. Now we've learned to do it on a catheter. Yay, of course that's better. And the complex part of it is that the gold standard for mitral disease, whether it's functional or degenerative, is really three things. It's going to be doing something to the annulus, or ring perhaps. In some patients, doing something to the leaflet, and in a default to a replacement. That's the gold standard of which I practice right now. I think eventually you'll see many cases become transvenous, minimally access with those three tools: a ring tool, a leaflet tool, and then a replacement.
That's interesting. Steve, what about approaching the left atrium for AFib, the tricuspid valve? Walk me through that progression.
So obviously the tricuspid valve is harder for us to image because it's further away from the esophagus. The TE right now is not as good seeing the right side, as you know, of course. But I think we're going to solve that in the future with the development of ICE technologies. ICE technologies is already being used in mitral, looking very directly at what we want to see, and I think you will see that be a great leap in tricuspid. You'll also see that in the left atrium. I think appendage closure and things like that will be helped with the use of ICE.
Interesting. So that these will come. You're not saying that all of this will be done during one procedure, but it might be staged procedures?
It might be staged procedures, and of course, when I'm doing a major surgery, I've asked you to pay a huge biologic price already. I better fix everything right there. Maybe I have to, maybe I should, maybe I shouldn't, but I'm only going to get there once. Now, with catheter-based procedures, maybe we can fix the mitral valve and hold off, and then do something in appendage and hold off, or do the tricuspid valve and so on like that. And I think the other thing is with these catheter procedures, we're going to get to the patients much earlier in the course of their disease. I mean, right now we see many of these patients, they're 99.9% dead by the time they come to us. I mean, rightly so. What we do is ask them to pay a big price, and therefore, of course, we don't have a good outcome. But I think as we go uphill in seeing the patients, because the price we ask for a catheter procedure is much less.
Let me ask you, you obviously are a very experienced mitral surgeon. You were before you did your first mitral clip. Doesn't that surgical experience of having seen it, been there, dealt with it, seen the anatomy, worked on it, didn't it accelerate your learning on transcatheter therapies?
Absolutely. Transcatheter therapies, I think, should be developed part and parcel between interventional cardiology and mitral surgeons. When I'm doing a clip myself and I have that clip down and I yank on something, I know what I'm yanking on.
That's right. Okay. So how does that impact training in the future?
I think really it behooves us and industry to sort of pull surgeons in the direction of transcatheter technologies. I think you'll see a change in that, I hope.
But that would impact the whole way you're training. I mean, does the, I think about it that, if I came to you you're doing a transcatheter therapy, something happens, but you've had extensive experience in landing the plane like Sully in the Hudson. But I mean, don't you need that? Don't you need some kind of, or no, you don't?
How we train people is going to change. You're absolutely right. And we're going to become a cardiovascular proceduralist, perhaps. But if you think of it, it's always been changing. People have said, you know, I was a fellow, myself personally 40 years ago. What do I do the same as I did 40 years ago? Give heparin, and at the end, give protamine. That's it. Everything else is different. And we will continue to evolve.
You were talking to me recently about pictures of patients who have had minimally invasive approach or things like that. Are you talking about little pixie holes here? What's the patient
Randy,
going to look like?
I think all those things will sort of go by the wayside. I mean, how long have we had robotic mitral repair? 29 years. We're really good. We would have figured out whether it's the best or not. I mean, how long have we had TAVR? 14 years. Now, everything is TAVR, as it should be. I think those will all go by the wayside. In 10 years, I think you'll have 30% of the patients having a sternotomy for complex disease and redos, and the rest of them, this will be minimal invasive.
So you said the magic thing will be a Band-Aid on the femoral vein? And
Band-Aid on the femoral vein, go home that day.
Sounds good to me. Anything else I can do? That sounds fabulous. Thank you very much.
Randy, thanks for having me.
You've taught me again. Thank you, and thank you for joining us.